Oh, let me make sure I'm recording. He speaks like 5 languages, and he's self-taught. I didn't teach him any of that because I speak English. I do live in Miami. I know a little Espanol, but it's not a lot. He's self-taught, and I learned that he knows all of these languages from his teachers. Like his teachers would ask me, who speaks German, or it does, Lily. The research does show that more boys are affected than girls. So yes, his teachers would ask me who speaks a certain language, and I say no one. No one in our family speaks German. No one in our family speaks Mandarin. No one in our family speaks Portuguese. And somehow my son is fluent in all of those languages. It's YouTube. He's self-taught. So yes, he's very smart, but he does have, the typical signs and symptoms of autism that we see a lot of. It is considered a genetic link to autism. The science, I think they trace it to the father. So there is research that supports the fathers are the ones who pass down the autistic gene. Maternal health while pregnant can have a play in a child developing autism. Social economic status. Now, there's a gray area with that there because I don't like to say because a person lives in a lower social economic class, that indicates their kids are more likely to get autism. I think this is about resources or access to resources. I think that's what that means. And then, of course, exposures to pollutants, metals, pesticides, other contaminants. So, signs and symptoms of autism. Now, there are domains that we look at. However, is there a higher chance of a male passing it to a child? Yes. Being that it's a man, an older man, based on the science of risk factors, yes, it would be a higher chance that an older male could pass it down if he were to have a child. Now, that is not all older men having babies, of course, but the research does point to that it is an increased chance for that to happen. So, autism in adults. Now, a lot of times we look at autism in children. And if you guys attend any of the pediatric webinars and they go over autism, they talk about how autism is diagnosed or the signs and symptoms in children. It is more or less about growth and development. When we look at autism in children, they're behind with skills like walking, crawling, talking, stuff like that. But with adults, and there's a lot of adults that go undiagnosed with autism. If you guys think about it, the kid that you knew in school that was shy, you called them shy or you called them awkward or they were weird, those types of things. Those are usually people that are on the spectrum and they may have not been properly diagnosed. So in adults with autism, they like to be alone. Um, Now this is kind of funny because I'm an only child and I do prefer to be alone and I'm not on the spectrum, but it's almost as if the issues with being in a social setting, it kind of makes them nervous or, they feel out of place or they don't know how to act in a social setting. So they prefer to stay alone because it makes them feel more comfortable. Adults with autism tends to overthink a lot. There's a lot of anxiety there. Issues with eye contact. Now, that is something that we see in children. One of the main clinical manifestations of autism in children is inability to maintain eye contact. Being inflexible to changes in routine. So we know that people with autism love routine. They love a structured environment. It helps them to process their environment and function. So when there is a sudden change in that routine, that can truly upset an individual with autism. So that is something that we see in children and adults. Okay. Trouble regulating emotions. Sometimes you hear that people are, you're too emotional, you're too this, or the emotions are kind of too much for the moment. Sometimes people with autism have trouble regulating their feelings, or they don't understand how to process what it is that they are feeling. We did say that people with autism tend to have a high IQ. That is normal. And they pay a lot of attention to detail. And that is my son. My son is very smart. He pays close attention to details. He will see something out of place and he just has to fix it. Um, he doesn't have the typical symptoms of autism like no eye contact, anxiety. He's very sociable, um, more sociable than I am, but he does have trouble with changes in routine. So thankfully, the school he goes to, they're really, really big on structure and routine, and that really does help people, children, and individuals of adults with autism. So how do we diagnose autism? So there's no one test. There is no labs, no, nothing individual that will say this person has autism, this person doesn't. Instead, it's a bunch of different things that go into helping the practitioner make a definitive diagnosis. So we do what is called a neurological assessment. 9 times out of 10, that is who will diagnose the person with autism. It would be a neurologist, as that is what their specialty is, and that would be the one to administer the exams to help with the diagnosis. We look at the history. So we look at things like if there was issues in development. We look at things like how do you, are you in a social setting? Are you comfortable? Are you shy? Do you feel awkward? Do you feel out of place? We look at behaviors. Okay, sometimes people with autism, they have what we call meltdowns. And then we look at the functional assessment. The lower the person is on the spectrum, the less functionable they are, or the less ADLs they're able to do. So simple things like getting themselves dressed, brushing teeth, brushing their hair, cooking as they get older, that tends to be a little bit problematic for people that are on the lower end of the spectrum. So, how do we treat autism? So, again, since this is not a one size fit all condition, there's no treatment that is one size fit all. Treatment is stemmed at what works. Sometimes it's, trial and error. We try one thing for a little while, we see it doesn't work. So, we say, let's try this or let's try that. So, we do a lot of positive reinforcement for people with autism. When we say positive reinforcement, this is kind of what the goals of cognitive behavior therapy is. And if you guys have been with me in the past, we talk a lot about cognitive behavior therapy with a lot of mental health disorders. This is where you put a lot of positive emphasis on behaviors that you like to see. Positive behaviors, good behaviors, functionable behaviors. You put the emphasis on that and you put less emphasis on the negative behaviors. So with more emphasis on positive behaviors, the goal is for the individual to continue those behaviors because, again, we are cognitively programming them to do those things. We do put kids on and adults on with autism on medication. Again, it depends on the client themselves. Sometimes anti-anxiety medications, mood stabilizers, maybe an antidepressant if necessary for an adult. Medications to help them focus, which we'll talk about with ADHD. So again, with autism, again, it's just figuring out what works for the client. And then there's the different types of therapy. ABA is one of the most common therapies that we see individuals with autism in, applied behavior analysis. It kind of, again, it's almost the same thing like cognitive behavior therapy. We focus on good behaviors. We kind of help the person learn how to behave in certain settings like school, out about in the real world, social settings. So, again, it's just about working on behaviors. Speech language, sometimes individuals with autism do have trouble with communication, so they benefit from speech language therapy, occupational therapy to help them do things like dress themselves, put on their clothing, tie their shoes, cook, drive a car as they get older. Sensory integration. So this is an important type of therapy. A lot of times people with autism have trouble with processing sensories. The world is full of sensory, things that appeal to your sight, seeing things that appeal to the hearing, touch, taste, all of your senses, something in the world appears to one of them. For people with autism, they sometimes have trouble with all of this sensory input that they are exposed to. It can almost be overwhelming. I'll give you guys an example. When my son was little, he had a problem with loud noises. He still has an issue with loud noises, but it's not as bad as it used to be. He would cover his ears for the entire time we was out somewhere because it was just so loud. Now, to me, it wasn't that loud, but to my son, I can only imagine how loud the noises were to him. So now he's gotten better to the point where he's able to adjust. He's older now, of course, so he's able to adjust to the noises around him. In the beginning, it might be too loud, but as he adjusts, he becomes more comfortable and he doesn't put his hands over his ears. Sometimes children, or adults, when they are exposed to a lot of stimulus, they become overwhelmed. They may have a meltdown. So sometimes we have to remove them from the situation to kind of get them over, the overstimulatedness to get that away. So the sensory integration therapy, it kind of helps individuals with autism process all of this information that is around them. And then, of course, social skills training. This is a big one also. Teaching people with autism how to behave in social settings. Again, the shy person, the awkward person, the person that feels out of place at a party. Those are sometimes people on the spectrum. So social skills teach these individuals how first to have a conversation, how to hold a conversation with someone, how to, wait in line, or what it means to wait your turn, or how to just go to the grocery store and shop. Little stuff like that, that helps with the social skills. It can even help with getting a job because, of course, individuals with autism, they are functional, contributing adults. They have jobs, they have kids, they get married. So we want them to be able to exist just like anybody else in the world. They just need a little bit of help sometimes with doing so. So, what is the nurse's responsibility when caring for an individual with autism? So, it's pretty simple. We know that the care is individualized, so it's up to the nurse to, assess the client to try to get an individualized plan of care going. We want to make sure we understand what their communication needs are. Some people with autism are very, very outspoken. They speak with no problem. They may have a little bit of time that they need to process the thoughts. However, they are able to speak just fine. And then you have some people with autism, we call them nonverbal, meaning they do not communicate. They may make little sounds to indicate what it is that they want, but they don't have verbal language. So do we use devices to help them speak? Do they write things down? Do they use one of those audio boards where they push, buttons and the words come out? Do we teach them how to sign language? Those are the ways we try to figure out how did this individual communicate. And then, of course, the sensory deprivation or the sensory overload, it can go both ways. We try to figure out what the sensory needs are. Okay. And then again, implementing positive behavior or reinforcing positive behavior, sensory friendly environments. There's a lot of places now that are catering to individuals with autism. For example, there's a place here my son loves to go. It is the Children's Museum here in Miami. And one Saturday a month, they have what is called Sensory Saturdays. So what they do is, the lights are not as bright, the music is not as loud. They have sensory rooms where if your kid, is having a meltdown, you can take them into this room. It's calming, it's relaxing. They use aromatherapy to help calm the kids down. And they only allow parents and children with autism until, they open to the general public. I know Chuck E. Cheese has autism sensory days. A lot of parks like Disney World, Universal Studios, they are now accommodating individuals with autisms and other sensory needs. They're training staff to be able to work with these individuals. So this is a good thing because before we didn't have that. So now we're just creating sensory friendly environments for individuals that have sensory needs like those with autism. Visual aids. Again, if the child or the person has issues with communicating, we use a visual aid. Okay. It helps to, get the communication across because again, not every person with autism has speech. Okay. And then positive social interactions. Once you get to a point to where as the person is comfortable going out, then we take the therapy into the streets or into a social setting. Okay. Any questions with autism? It's not a lot there. You just know that again, everybody is different. It's a spectrum disorder, routine, positive behaviors, and you just know your manifestations. And that's pretty much it to autism. It's not a lot there. So let's jump right into ADHD and then we'll take our first breather. So ADHD, also known as attention deficit hyperactivity disorder. Now there is another disorder known as ADD. So this, let me make sure. Why did it say that my speaking language is Spanish? Let me save to make sure. So when it comes to ADD, you have the same signs and symptoms, except you don't have the hyperactivity component. So we will talk about ADHD, and then of course, it's pretty much the same thing with ADD, you just don't have the hyperactivity. So what exactly is ADHD? So ADHD is again another type of spectrum disorder. It is not one size fit all. However, there are noticeable disability or inappropriate degrees in three domains. That will be inattention, hyperactivity, and impulsiveness. So individuals with ADHD, they have trouble with, again, inattention or focusing, hyperactivity, and impulsiveness. So when it comes to the inattention, we kind of see it first in a school type setting. As a matter of fact, that is where it first comes up that the kid might probably have ADHD. It is the teacher that notices, the child has trouble focusing, they're disruptive, they might be a little bit hyperactive. So it would be the teacher who normally brings the possibility up to a parent or a caregiver that their child may have ADHD, or to get them checked by a neurologist just to see what is going on. The hyperactivity, it feels like you can't sit down. You got to move. You got to do something. I had a patient with ADHD one time tell me that when he had his hyperactivity moments, it would feel like a balloon is filling up with air in his body. And then when the balloon bursts, it's like he has all of this energy that just has to come out. Like he has to run, he has to do something, he has to jump, he has to move, he has to do something because he has all of this energy pinned up inside of him and he just can't sit still. And then lastly, you have impulsiveness. So when a person is impulsive, they do things a lot without thinking. Now, this is where there's a safety concern for individuals with autism, because when you are impulsive, you don't stop to think, can I hurt myself if I do that? A person who's impulsive, they see a body of water and they just want to jump in it, not considering, is it deep? Is it an alligator in there? Can I even swim? To the point to where I could just jump in water, not knowing how deep it is. They just do. Kids, running out into the street, kids leaving the home, it's like they have the impulsive to just do something and they don't consider the consequences, or could they get hurt? So again, safety is a huge concern for individuals with ADHD. So these are the risk factors for ADHD. There is also a genetic component there. So if you have a blood relative or a sibling with ADHD, you can develop it also, or it can start to manifest. Environmental toxins are also believed to be the cause of ADHD, just like with autism. Exposure while pregnant can increase the risk of a child developing ADHD. Preemies tend to have a higher developmental rate of ADHD than others. Illnesses, injuries that affects the brain, being male. So here we have another condition that boys are more affected than girls or women. So yes, we tend to see more men or males with ADHD, just like we see more males with autism. So these are your manifestations of ADHD. And again, this is not one size fit all, which means some people may show some of these signs, some people may show a lot of these signs, some people may have other signs and symptoms altogether. So this is what ADHD looks like in adults. So in addition to the inability to focus, the hyperactivity and impulsiveness, we also see disorganization. The person has trouble remaining organized, very forgetful, distracted very easily, very restless, get irritable very, very easily, gets excited very, very easily, bored very easily. They make little mistakes that they normally wouldn't make if they were able to focus and pay attention. Poor time management, poor stress management skills, and very hot tempered, or they get mad very, very easily. So these are more of the mature manifestations of ADHD that we see in adults. So how do we diagnose ADHD? Very simple, kind of similar to autism. Okay, we discuss the signs and symptoms either with the client themselves if they're old enough, or a parent of a child that may possibly have ADHD. And then we might want to observe the client in a habitat or an environment. We don't like to let the client know that they're being observed because we want to see them in their natural form. Okay. There's other guidelines by the American Psychiatric Association that helps with differentiating between ADHD and other manifestation symptoms. And we kind of look at external factors that helps to, increase the signs and symptoms of ADHD. So once a diagnosis is made, treatment is also similar to autism. We may put the client on medication. Okay. I know you guys heard of Ritalin. You know, that used to be the hallmark drug for managing autism. However, a lot of parents did not like Ritalin because while it did control the symptoms, it kind of made people zombies. If that's the best way that I can put it. People are very sleepy, very drowsy, they're not, you know, altered levels of consciousness. It's almost like sometimes people were sleepwalking or they just slept a lot on Ritalin. And sometimes no matter how much dosages was altered, you still had some type of a depressed type mental state for these individuals on Ritalin. They have other drugs. They use antipsychotics to treat ADHD, stabilizers to treat ADHD. Again, this is not one size fit all. Therapy is also indicated. Cognitive behavior therapy, where we focus on positive reinforcement. Mindfulness training. So this is a new one. Mindfulness kind of helps the individual understand and process how they are existing in their environment. It kind of puts the accountability on the person. You know, how do I exist? How do I get upset? How do I calm down? And if the person has that awareness, the goal, hopefully, is that they can manage their symptoms a little bit better. Or when they realize that they're becoming hyperactive, they can kind of focus and hopefully calm that activity down. So mindfulness is really, really great for adults that are experiencing ADHD type symptoms. And then again, you get into the treatment of neurofeedback. Okay, so neurofeedback uses brainwave activities to help individuals learn how to control their brain functioning. Okay, so basically, what we do is we will put electrodes or some type of device on the clients around the head. And what we do is we expose them to different things. And based off of the feedback that we get, we show this to the individual, and they then can help themselves learn how to process and deal with things in their environment. Again, it's almost like you are providing your own visual cue or your own audio cue. Okay, this is your own body's reactions to your environment, to sensory processing, and you get this feedback and you say, okay, when I'm around certain things like this, my brain tends to do this, or I tend to feel this way. So now that I'm aware that I behave this way or I feel this way, let's see what I can do to help, control that in the future if I am exposed to that particular type of sensory or stimulus again. Okay. So basically, in order for neurofeedback to work, the person has to be open to learning things about themselves. It may not be pretty, but they are open to learning. Neuromodulation is another type of treatment where we alter nerve activity. Okay, so we will stimulate certain areas in the brain, certain areas in the spinal cord, and through that stimulation, you are going to see how the individual reacts when exposed to a certain type of stimulus. It is a highly personalized type of therapy. It allows the person to see chemically, neurologically, how do they react to certain types of stimulus. It can be a good stimulus, it can be a bad stimulus, it can be triggered by certain emotions, triggered by certain memories, but we try to change or alter the way the person responds when they are, stimulated by certain things. So, for example, if I was exposed to a trigger that would normally, make me feel bad or have a negative impact, the goal, hopefully, with neuromodulation is that that stimulus would no longer trigger those types of feelings in me with treatment over time. Okay. And that is how we try to help control symptoms in individuals with ADHD. Management. So if I am the nurse caring for an individual with ADHD, I understand that I need to take a good health history to help with making a diagnosis. I want to support structure. Again, people with ADHD and autism, they need structure. Okay. Making sure I take the approach to understanding what the client needs individually. Again, no one person is the same as another that has ADHD. Everybody has individual specialized needs. Making sure that the client is able to meet their basic needs. If they're not able to do it themselves, then I am there as a supporting factor. Make sure that individuals are compliant with medication. One of the things that we notice is when a condition is not improving the way we expect it to, one of the first reasons is the person is not compliant with the drug therapy. Now, if this is due to side effects, then as the nurse, it's my job to say, why aren't you following your medication regimen? Like, why aren't you taking your medications like you're supposed to? Is there something wrong? Because if there is serious side effects, then a lot of people are not going to take the medication. That means we need to work with the healthcare provider to figure out what will work for this client. Making sure that the client and the family is properly educated on the condition and ways to support the client. And lastly, how do we manipulate the environment or modify the environment so that it is supportive for the individual? Like, for example, if the individual is having trouble on a certain type of day, is there a support system in the home or support system somewhere that can come and assist the client if they need help? Okay, so those are the webinar content training for autism and ADHD. Do we have any questions? They are very similar. The good news is, although they are different conditions, they are very similar in terms of treatment, diagnosis, and management. Okay, it is 9:45. So let's do a 10-minute breather. We will come back at 9:55 and we will continue with dementia. So 10-minute break, everyone. 9:55 we'll be back. Okay, I just see a question from Miss Esther. Which drug is most recommended in treating ADHD? Okay, so that is a great question. So unfortunately, there is no one drug that is recommended over the others. Again, this is almost like a cause and effect, trial and error type thing. Um, Again, you have drugs like um Ritalin, a lot of stimulants. Believe it or not, stimulant drugs are used to treat ADHD, but not stimulant in the way that you would think, because a person that has hyperactivity, you do not want to stimulate them anymore. But these are stimulants that, stimulate certain receptors in the brain to calm down the hyperactivity. Sometimes antihypertensives can help to modulate and bring down hyperactivity. So the goal is to clear focus and to bring down the hyperactive activity. But typically, any drug that falls in the stimulant category, that would be the first line of drug treatment to manage ADHD. You're welcome. Concerta, Adderall, yes. Those are stimulants. Absolutely. Thank you, Pete. Yes. Adderall, Concerta, Ritalin, those are all stimulants. Yes. I know that one of the things that we saw with the stimulants or the research shown is that they help to improve the neurotransmitters in the brain. And if you guys know what neurotransmitters are, your epinephrines and stuff like that. So the stimulants are improving the neurotransmitters, and that in turn is supposed to help with the functioning of the brain to kind of control those symptoms. So that's pretty much what the stimulant is there for.
you're feeling.
Okay, everyone. Let me see. Yes, okay, I see. I'm just looking in the chat, catching up. Hello, Miss Juliet. Thank you for joining. Yes, we just did autism and ADHD, so now we're getting into dementia.
I wasn't able to get in. I was trying, even for the 7 o'clock one, I was trying and could not get
Oh,
in.
I'm sorry, but yes, you do have the option to watch the recording. Okay, so let's get into dementia. So, what is dementia? Dementia is an umbrella term. So, it is not a condition by itself, but it is an umbrella term for a group of neurocognitive disorders. So, basically, it is just a decline in neurological functioning. So, things such as memory, language, mobility, recognizing familiar things, the ability to reason, the ability to plan, all of those neurocognitive activities, there is a steady decline. There is no cure for dementia. The best thing that we can do is slow down the progression of the disorder, but it is a progressively declining neurocognitive condition. Um, Eventually, the individual will become very impaired. They will not be able to walk. They may lose the ability to talk. They definitely will not be able to do any daily activities, such as, getting themselves dressed, cleaning themselves, cooking, anything like that. They will be totally dependent on their caregivers for care and support. Eventually, it does get to that. The most common type of dementia is called Alzheimer's, and we will discuss that condition after we do our break after dementia. So, there are different types of dementia. Again, this is not a disease by itself, but rather than a term used to describe a decline in neural functioning. So, the most common is Alzheimer's. About 60 to 70% of dementia cases do fall under the type Alzheimer's. There is another type of dementia called vascular dementia. This is when you have injuries to blood vessels. And when you have injury to blood vessels, it causes a decrease in perfusion to the brain. And when you have a consistent decrease in perfusion, you start to see damage to the brain. The brain is the only organ that cannot regenerate itself after it has suffered irreparable damage. So, unfortunately, if you have a chronic decline in perfusion and oxygenation, you will see damage to brain areas, and then you will start to see the signs and symptoms of dementia. You have something called frontotemporal dementia. And this is a dementia where there is damage to the frontal and temporal lobes of the brain. So, brain functioning that comes from those areas is affected. You have another dementia called Lewy body. This is a 5% case of dementia with this type. Protein deposits are found on the brain, and usually we see this after the person has passed away and they do autopsies. Hold on, give me 1 second, you guys. Okay. So normally we see that type of autism after the fact, like for example, when an autopsy is performed, you will see protein type deposits onto the brain. It kind of mimics a psychiatric type disorder because the individual may have a lot of hallucinations, disturbed sleep patterns, in addition to the decline in neurocognitive functioning. And then there's other types of dementia. These are the other types that do not fit into any of the other categories. This could be Parkinson's, Huntington's, and other type the dementias where you see the decline in neurofunctioning. So these are your risk factors for dementia. So we categorize the risk factors into two different ways, modifiable and non-modifiable risk factors. So you guys, what is a modifiable risk factor and what is a non-modifiable risk factor?
Just like lifestyle, like a lifestyle changes.
So that would be modifiable. And what makes it
Yes,
modifiable?
because it can change.
That's exactly what I'm looking for. Perfect. A modifiable risk factor is something that you have control over, something that you can change. Okay. So when we talk about risk factors, we talk about modifiable risk factors such as, yes, smoking, okay, weight gain, weight loss, um, medical conditions, believe it or not. For example, if I have hypertension, um, I can take medications, I can, do things that are heart healthy. I can improve my diet. Those are things that I can modify because cardiovascular disease is definitely a huge risk factor for dementia. Anytime you have a condition that interferes with perfusion to the brain, you have a risk for developing dementia. So, again, cardiovascular diseases such as hypertension, myocardial infarctions, um, DVTs, those types, blood clots that can travel to the brain and block blood flow. Okay. Physical inactivity. The more you are sedentary or the more you are not active, the higher the risk for dementia as you get older. And then we talk about non-modifiable risk factors. Non-modifiable risk factors are the opposite of modifiable. So if modifiable risk factors are things that we can change or things that we can control, that means non-modifiable risk factors are those things that we cannot control or something that we have no hand in. So for example, our age, we cannot control getting older. We can do all the treatments and the beauty, injections and as many surgeries as we can get. And, we exercise 24/7 hours a day. It is still not going to change the fact that we are going to age. Our body systems are going to slowly age. That is something that we cannot control. Family history is something that you cannot control. If dementia or any other medical condition runs in your family and there is a genetic component, then yes, you are at risk for developing it also. So when we talk about genetics, we look at close family. So parents, siblings, aunts, grandparents. Okay, those tend to be the close relatives that we talk about. when we say the risk factors for developing the condition when it comes to genetics. Okay. So these are the typical manifestations of dementia. Okay. So problems with communicating. And remember, since this is a progressive, non-modified, yes, thank you, Nikki Ann. Perfect. So signs and symptoms. So when we talk about signs and symptoms, remember this is a umbrella condition, different types of dementia. And when we talk about the symptoms, we want to make sure that caregivers and individuals understand this is a progressively functioning condition, which means these symptoms may start out very mild. Okay. As a matter of fact, you can very well see the signs and symptoms of dementia in people. It's just that they're so vague that you miss it. For example, forgetfulness. That's a huge one. You start to become really, really forgetful. You always misplacing something. I just had my keys. Where are my glasses? Or I thought I put this place. And it starts out very small. Okay. No one is going to see someone forgetful and automatically think this person is developing dementia. Then you start having trouble with tasks, simple tasks that you shouldn't have any trouble completing. You start to have trouble completing stuff. You notice that you are getting more confused in terms of time, person, and place. You start forgetting names, or you have trouble remembering names, or, what time is it? You seem to lose track of time a lot. You have trouble solving easy equations that you normally had no trouble solving. Then you start to notice my communication skills are not where they should be. You start having trouble finding certain words to say certain things, or you find yourself having to think a lot more before you speak. Okay. So those are the signs that you start to see, and then they get progressively worse. Again, it is very important that we make sure that caregivers understand, or people that are, with the client, this is a progressively functioning disorder. This is not going to get better. It is going to get slowly worse over time. The best thing that we can do in terms of treatment is to slow down the progression and keep the person as functionable as we can until they are 100% dependent on care. So this is how we would diagnose dementia. Okay. Oh, let me see into the chat. Which sex is more at risk? So that's a good question. For certain types of dementia, men are more at risk. If you notice, there's a little bit of a pattern here. Okay. Men, take care of your brains. Now, if it runs in the family, if there's a family link to it, then of course it just doesn't matter if you're male or female, if there's a genetic link to it. So how do we diagnose? We can do a medical evaluation. So we will do a detailed history and a cognitive test. The cognitive test is very telling. It could be a series of little small tests, little equations, little puzzles, things that a person of a certain age should have no trouble completing. And we kind of time the person to see how long they would take to complete these little activities. And that kind of helps the practitioner with making a diagnosis. We could do some brain scans, some brain images, and that's going to help us to see how damaged the brain is, or what areas of the brain is affected. It also helps to rule out other conditions, because you want to make sure that when you are diagnosing a person with dementia, that you are accurately diagnosing them and that you are not, missing something else. Okay. Biomarker test. This is something that we can do in terms of blood work. Now, this is not definitive in terms of helping with diagnosing dementia. However, we look for certain markers in the blood, and depending on the markers that we see, it is more likely to be a particular type of dementia. And that is where the brain imaging and the other exams will come to help diagnose whether or not it is exactly what the marker hinted it to be. So treating dementia. So again, this is not a curable disease or condition. It's a progressively progressively functioning disorder where the person will lose their ability to do certain neurocognitive activities, certain basic skills. We can put the client on medication. However, there's going to come a time where the medication will no longer work or it will no longer be able to control symptoms. Therapies to keep the client functionable. Sometimes memory activities do help keep the brain, working and keep working out the brain. Think of it like brain exercises. Showing the clients pictures, talking about stories that are familiar. Those are things that helps with memory. Lifestyle changes. We try to adjust the client's daily activities based on their ability to do functionable activities. Of course, we provide counseling and support. It's not easy to learn that you or somebody you love has a condition and they're not going to get better. They're going to progressively get worse. And there comes a time where they may not remember you. They may not be able to talk. They won't be able to walk. They won't be able to care for themselves. They will be completely 100% dependent on care at some point. Now, non-medication treatments, of course, we can always put the client in therapy. That is to help keep them mobily functionable. Okay. If there is a psychosocial component, meaning the person is having a hard time adjusting, whether it is the client or a family member, we can always try psychotherapy. Okay, we can teach relaxation techniques, speech therapy to keep the language there as long as we can possibly have it there, and then support groups. Sometimes it helps to talk to other people that are going through the same thing that you are going through, or a caregiver support group, because caregiver strain is real. One of the things that I encourage anyone who is a caregiver to do is try to make arrangements where you could take some time for yourself, because caregiver strain, caregiver blowout, that is a real concept. And when you are a caregiver 24 hours a day, or you have to work and then come home and take care of a sick person, that can weigh on the caregiver as well. So we try to do support groups for everyone that is involved with the client.
That's true. And then because some of the family members they don't understand what is dementia, so they tends to not being able to cope with it. Because my mother-in-law, she has dementia early stage, but it's like my husband and my sister-in-law and stuff, the least good thing that she does, they just shouted at her and like they want her to be like what she was. And I'm like, you can't, you have to understand this is a progressive thing. You got to learn about dementia and how to care for her and stuff. But the least thing, like they just get mad at her.
You know what? That is true. A lot of times we have to educate the caregiver because we try to. It is true they get frustrated, they get angry, and it's almost like they don't understand the person is not doing this on purpose. When there is a decline in cognitive functioning, the person becomes childlike. They slowly decline, and they're dependent, they're childlike. So they do things, as a child would do. They get into things. They might, spill things, they might break things. They become confused, they may become combative.
Yeah.
Um, so yes, we try to make sure that the caregivers understand exactly what is happening so that they're able to cope, because having good coping skills is also going to help through the process, because it can become frustrating, it can become difficult. There can be times where you're not sure if I am the right type of caregiver. Do I need to put my family member into a care facility? A lot of people don't like to make that decision, but sometimes the needs of the person is beyond the control of the caregiver. So then it would be beneficial to probably look into alternative places to provide care. So we definitely have to focus on the caregivers themselves when it comes to managing a loved one that has this condition, because it is stressful. It is a lot. Someone in the chat asked about resources. I'll be very honest with you. The resources are great. Oh, Miss Nikki Ann is answering. I was just about to say the resources are very helpful. It helps that you answer so many questions a day because that is how you're going to prepare for the NCLEX. You have to be comfortable with the questions because you're not going to know where the questions are going to come from. There is no blueprint for the NCLEX, nothing to tell you this is what you're going to see on your test. You literally sit down, start the test, and the questions just randomly come at you. The only thing that you do know is that as you answer a question correctly, the next question will be harder. Okay. Um, so that's it. I think that was the last thing we talked about, educating and supporting caregivers and family members of those with dementia. So we come to the next point of break. It is 10:15. Let's do another 10-minute breather. And then we will finish with Alzheimer's, and then we will go right into our NCLEX questions. So it is 10:15. Let's come back at 10:25, and then we will continue. Everyone, let's finish Alzheimer's and then we're going to jump right into our NCLEX review questions. So, Alzheimer's disease, as you guys remember, this is the number one type of dementia that we see. So, hello, Miss Lovely. So, webinars are scheduled 7 days a week between the time frames of 7 to 9 p.m. Eastern Standard Time and then 9 to 11 p.m. Eastern Standard Time. So you simply go into the dashboard, the scheduling center to see what topics are being offered, what night, and you simply just sign up for whatever topic that you want to attend. So there are 7 days a week. So exactly, you're welcome. So what is Alzheimer's disease? So again, this is a type of dementia. It is a progressive brain disorder. It affects pretty much everything cognitive functioning, memory, the ability to think, the ability to be sociable, even the ability to be mobile. Everything that involves brain activity will slowly decline in terms of functionality. It basically starts to interfere with your abilities to complete daily life activities. So the simple tasks that we probably take for granted, that is something that becomes problematic for people with Alzheimer's. It also affects the way a person emotionally responds to things. It does develop more in people over the age of 65. That is typically when it is most diagnosed. However, you can see the symptoms a little earlier than that particular age. Because remember what I said, sometimes the symptoms are very vague. You see them, but you're not really realizing that it is turning into something like dementia or Alzheimer's. So these are the risk factors for developing Alzheimer's. And as you can see, it's pretty much the same thing like dementia. Remember, Alzheimer is just the more prevalent type of dementia. So family history. Okay, so if there's a family history of Alzheimer's, close relatives, then your risk is there also. Age, again, over the age of 65. Pre-existing medical conditions, any type of cardiovascular condition that interferes with perfusion and oxygenation to the brain, or any cardiovascular condition that destroys vessels, because blood vessels are what carries blood to the brain. So anything like that increases your risk for developing Alzheimer's. Lifestyle factors. So if you are overweight, if you are a smoker, if bad dietary choices like eating a lot of salt when you're hypertensive, those types of things. And being sedentary, so not, exercising, minimally exercising. We don't expect you to do, full-blown workouts, but if you're just getting up off the couch and moving around 30 minutes 3 times a week, that is considered something affective. Genetic, so it does run in families. Okay, if there is a genetic link, then there's a possibility for the individual to develop Alzheimer's. And these are your typical signs and symptoms. Okay, so memory loss that disrupts daily life. So it's more than just, I forgot what happened last week, or I forgot this person's name. We're talking about memory loss that interferes with your daily functioning. That is the severity. Forgetting where you live, forgetting where you work, forgetting the names of children, forgetting the names of your spouses. That is when we say it interrupts daily life. Okay. Challenges with planning or solving problems. Again, basic little activities that you would think a person should have no trouble working out, they're having trouble with. Losing the ability to communicate over time. Weight loss. And a person seems to drop weight very, very quickly. And that is because their eating habits also change as well. You start to notice that mobility starts to decline. They're not walking as well. Their balance is not well. That means that they are at risk for falling. Okay. The muscles become weakened, the muscles become contracted. That is why therapy helps to keep the client limber. They may have trouble sitting still or standing for periods of time, and they may develop something called apraxia, which means loss of voluntary motor functioning. Voluntary motor functioning is the ability to move my extremities on my own. So it's things like walking, picking up a utensil to eat, picking up something to brush my teeth with, to brush my hair. Those are voluntary motor functionings, and they will lose ability to do that. Um, Another thing that I don't think I talked about, or it may come up, but I want to mention it in signs and symptoms, wandering. That is something that we also see in clients with dementia and Alzheimer's, the wandering. And when we say wandering, one day they just get up and go out the door. And you sometimes see it a lot on the news, a missing persons, silver alert. When you see a silver alert, that's an older person that is missing. And, they just get up and walk out the door. It doesn't matter the time of the day, time of the night. Sometimes symptoms are a little worse at certain times of the day for certain people, but they just get up and walk out, whether they have a reason to believe they need to leave or they just simply get up and go out the door. And it becomes a little frightening for people because, the loved one becomes lost. They don't know where they are. They may walk into a body of water and not realizing that they're walking into a body of water. So the wandering is very problematic for a lot of clients. So when we do talk about supporting the family, that is one of the main things that we help them, to manage, because wandering is a huge sign and symptom for an individual with Alzheimer's and dementia. So this is how we diagnose Alzheimer's, similar to how we diagnose dementia. There will be a medical assessment. There even will be a mental status evaluation. A lot of times people with Alzheimer's, they may develop depression, the cognitive decline, the being alone, that can put them in a very, very dark place. The memory in the mind doesn't go 100% right away. It is a slow decline. Sometimes people are aware of what is happening, and then sometimes people are not aware of exactly what is happening to the body. The brain scans will help us to determine what areas of the brain are affected or how damaged the particular area is. And then we do a physical exam or a functioning exam. I want to see the client walk. I want to see the client pick up a spoon. I want to see the client pick up a toothbrush. How do you button your clothes? How do you put on your shoes? Can you tie your shoelaces? We want to do a physical, head to toe. And then we definitely want to do a functionable exam, because that is going to tell us where in the disease process the client is, or how much dependency the client may have for others to assist them. So treatment is also similar to that of dementia. We make sure that the family understands there is no cure. Okay, this is a progressive disorders. Treatments helps to manage symptoms. It helps to slow down the progression. However, it does not stop. Eventually, medications and treatment is going to stop working, and there will be a steady decline. But for as long as we can, we try to manage symptoms and slow the progression of the disorder. Medications, specifically medications for Parkinson's, for Alzheimer's disease, cholinesterase inhibitors. Okay. Sometimes what these medications do is they simply improve symptoms. So, for example, if I have a client that has poor motor functioning, okay, I expect the medications to improve their mobility. Okay. If I have a client that has issues with memory or memorization of very basic things, I would expect their memory to improve. Now, we're not saying again that it's going to, enhance completely. But what we're saying is it's going to get a little better. It's going to improve at least. And again, it totally depends on what areas the client is lacking in. That is going to help determine what medications are needed. When you have a neurotransmitter, and I think I've talked about neurotransmitters before. Neurotransmitters is like brain food. When your brain has sufficient neurotransmitters, it helps to function properly. Okay. Without neurotransmitters, your brain is not going to function appropriately. And a lot of these medications, when we say slow down the progression, we're talking about preserving neurotransmitters, because with neurotransmitters, we see an improvement in symptoms. So if I give a client a medication to improve Alzheimer's symptoms, I'm giving them medication to support neurotransmitters, either prevent them from breaking down early or improve their production of the neurotransmitter itself. Okay. Cognitive stimulation. These are different types of therapies to get the brain functioning and to get the brain working. Okay. And then again, supportive care, not just support for the client, but support for caregivers and those that will be in charge of their care. Because remember, being that this is a progressively declining disorder, there is going to be a time where this person is going to be 100% dependent on care. They may not even be able to get out of bed. Okay, so nursing management for this client, you want to create a safe and supportive environment. Sometimes when individuals with Alzheimer's suffer from periods of confusion, it can be a safety concern. Confusion can also improve the chances of wandering. I'll give you guys a perfect example. If you have an older individual that is suffering from Alzheimer's and they are put into a nursing home or a long-term care facility, the individual may feel confused. They may not know 100% what's going on, but they still have some cognitive functioning to at least notice this is not my home, this is not something that I'm used to, so this is going to cause confusion. The confusion can make them combative, the confusion can make them a danger to themselves, to others, or the confusion can cause them to wander. I need to go home. Okay. They may not know what home is, but they know where they are is not home. So I need to go. I need to go home. I need to get back to whatever is familiar. And that will cause them to wander. So creating a safe and therapeutic supportive environment focuses on minimizing the confusion, minimizing the danger risks such as the wandering. Consistent care. Okay. Because these clients have difficulties with memory, confusion, combativeness, we want to try to keep caregivers consistent. If the nurses or the caregivers are going to be on shift back to back to back, we try to assign them to the same client. This not only helps to minimize confusion, but it helps to establish rapport or a relationship. Okay. Sometimes people with dementia and Alzheimer's, they have a preference for a particular face or they have a preference for a particular person. They do start forgetting people, but they have some type of something that helps them to remember. And whatever triggers that memory, we want to keep it going. So if we have to schedule the same individual to care for the client, whether it be a nurse or a CNA, we try to keep the same people involved in care routine. Managing symptoms. So this is where the medication comes in. Again, we want to make sure that the emphasis is placed on the fact that there is no cure. It's just a progressive decline in functioning, but we try to keep the client as functionable for as long as we possibly can. Um, we may do a lot of visual aids, a lot of visual prompters, therapy, cognitive behavior therapy, trying to keep them communicating, even if it's not vocally. A lot of that stuff we try to do to manage the symptoms. We adjust the care based on the client's symptoms or their limitations. More nursing management, educating caregivers, which we did have a little bit of discussion with earlier. We want to make sure that caregivers understand this is a progressive disorder. We don't want to get anyone's hopes up, that the medication or the treatment is going to improve or cure their loved one. We want to make sure that caregivers and loved ones have access to resources, support groups, and again, ways to manage their own stress, because this is a stressful situation for anybody to deal with. Again, to see their loved one decline the way that they will with this condition. And then promoting independence of life. As long as the client is functionable, as long as they are able to do their own ADLs, activities of daily living, we want to support that. Okay. We want to support them staying social. If they like going to bingo, you can go with them, take them to bingo. You might have to help them, do the boards and put the chips onto the numbers, but that is something that they enjoy doing. And that is something we want to promote more of. And again, as much as their own care that they can do, we want them to do as much. Okay. It keeps them functioning. It keeps the brain working. And again, we do this until the client is totally dependent and they cannot do anything for themselves. So that is the end for Alzheimer's. So we've covered autism, ADHD, dementia, and Alzheimer's. So autism and ADHD are very similar in nature. Dementia is an umbrella term. Alzheimer is a type of dementia. So there was a lot of connections with tonight's content. Okay. And when you have conditions like that, try to make the connections. That's going to help you guys when you're studying for the NCLEX. Again, this is going to be a lot of information that you guys are going to cover. And it's hard to remember everything. So if you start making connections or grouping things together, it makes it easier to recall information. So I'm looking in the chat. I saw a question like a client walk out the door and the security brought back to the facility. Should you write a report? Manager, risk manager, or call supervisor and the charge nurse. So I would have to see more of the question in context. Um, but I would first talk to the charge nurse. Um, I don't know. Like I said, I need to see the question in the whole question for context because it is an incident at the end of the day that somebody got out. But yeah, I would have to see the guidelines or the surrounding background to that question. So right now I'm going to share another screen. Okay, and this will be our in-class questions. So we're going to go through 10 questions and you guys can type your answers into the chat. We will discuss the answers, the rationales. Okay, so question number one, get ready to type into the chat. Question number one. The nurse cares for a client with autism who has been admitted to the hospital. Which intervention should the nurse include in the plan of care? Select all that apply. A, allow a family member in the room 24 hours per day. B, encourage the client to alert the nurse whenever they are in pain. C, dim lights and keep noise levels low. D, implement routines in the client's care. E, bring in possessions from home. So if you are caring for a client with autism and understanding what autism is, what would you do for your client? Now, notice it doesn't mention a diagnosis because a diagnosis is irrelevant. The client still has autism regardless of what diagnosis they have. So I am looking into the chat. I see ACDE, BCD, BCD, ADE. Okay, we're kind of all over the place. Now I finally got a question that has stumped y'all a little
ACD.
bit. Normally, y'all be saying the same thing with the answers, and I'm like, I got to get better questions. So we're a little bit all over the place with this one. So let's see what the answer is. The answers are ACDE, and I did see someone put that AC. As a matter of fact, it was Nikki, ACDE. I see an ADE, CD. Okay, so let's talk about why these are the answers. Everything except B. So I'm going to go back so we can view the answers. So allowing a family member to stay in the room 24 hours a day, that does provide comfort. We typically like people to stay with individuals that have some type of dependency or impairment. For example, we like people to stay with children. Depending on the cognitive level of the individual with autism, they may be functioning on a childlike level. So we definitely want somebody to stay to make them comfortable. Okay. And plus, a familiar face in an unfamiliar place could help the client adjust a little better. Now, the reason why B is not the answer, even though it seems like it makes sense, keep in mind people with autism may have trouble with communicating. So the nurse encouraging the client to alert them whenever they are in pain, that might be something that is beyond that person's capability to do. Not that they don't understand that they're feeling pain because they feel pain. They just may not be able to verbalize or communicate that they're feeling pain. So instead, the nurse should just regularly assess the client using developmentally appropriate pain assessment tools. Okay, dimming the lights and keeping the noise levels low. That helps to foster sensory input issues. Remember, sometimes people with autism, they get a little bit overwhelmed with the sensory. So dim lights, quiet spaces may help them a little bit better with coping with the environment. Routines, we said people with autism, they benefit from routines, they benefit from structure. And lastly, bringing something from home helps them feel, safe, secure, and is familiar. Okay, so everything except B, only because B is about communication, and individuals with autism do not have the best communication skills. Okay, question number two. A client with Alzheimer's disease is admitted to an inpatient setting and has memory loss, wandering, and disorientation. What nursing intervention should be the priority to initiate in the client's plan. So when it comes to NCLEX and prioritization questions, keep in mind, you are not saying that the other options are not important. All of the options may be important. All of the options may be applicable to your client. You're simply just stating, what would I prioritize? What is the first thing that I need to take care of before I do anything else? Okay, that is what prioritization questions mean. So in the chat, I'm looking at a lot of C's, safety. Yes, I see a D, a lot of C's and a D. So let's see what the answer is. C. The answer is C. So let's go back to the answers so we can see them as we discuss them. Yes. I think someone trying to answer a question.
I thought for the patient with Alzheimer, we have to redirect people for
Say that again. I didn't catch it. You
we
thought
have
what?
the client to the environment every hour.
Oh, okay. So we're going to actually discuss why
Yeah, but
D is not the
safety is
answer.
important.
Yes, that is important. That is important. But let's look at the rationale. It's almost like the prior question about the first question about
Yeah, safety is a
the
priority.
person with autism that you keep, tell them to communicate something. So when it comes to prioritization for a person with Alzheimer's, when they are showing signs of disorientation, memory loss, and wandering, that is a health risk. That is a safety risk. Okay. So we want to prioritize the risk for injury to themselves. Okay. So the very first thing that we will do, because remember, those are the symptoms that the client is currently experiencing. There is no time frame for how long they would be in that state of confusion, wandering, disorientation, memory loss. Okay. We don't know if the medications will improve those conditions or this is where they are permanently. So the first thing that you would like to do, you need to create a safe environment. That is the first thing you do. It's not saying that the other stuff is not important, but based on the client's current status, you need to make sure that there are no hazards in the client's environment that can hurt them. Okay. Now, written reminders. Remember, as they slowly start the cognitive decline, written reminders might be fruitful. Okay. It might not do anything to write anything down for this client. Okay. That is a way to look at it. You can also use Maslow to answer this question. Maslow says once physiological needs are met, then you can go into safety. And with this particular client, there's nothing physiological that needs to be met. So the next concern would be safety. Provide standby assistance and wheeled walker for ambulating. That is definitely not the priority. This client is at risk for falls. Remember, the more they progress, the more the mobility also changes. So giving them walkers and assistive, walking devices for them to use by themselves, they could definitely fall. Okay. Reorienting the client to the environment every hour. So that is what makes D not the answer. I'm going to actually go to the rationale so I can read it for you. Exactly. So, routine orientation is not recommended for clients in the later stages of dementia. Remember, this is all about cognitive impairment. Ooh, how did I do that? This is all about cognitive impairment. How did we get so far ahead? My computer is so sensitive, y'all. Like I can just cough, touch, and my computer gonna start jumping ahead in the slides. So, again, this client is clearly in the later stages of dementia. It told you that they have, disorientation, memory loss, wandering. This is late signs of dementia. Because remember what I said in the beginning, the signs are very, very vague. Okay. You see the signs, but you don't really know that's what it is until they start getting worse as the condition progresses. So once you are in the later stages, it's really pointless to keep talking to the client, to keep orientating the client, because soon after you finish with the orientation, they're not going to remember, it's not going to register where they are or what's going on. So instead, you focus on what you can control, which would be the environment and anything hazardous in it. Okay. Now, if the client was in the earlier stages of Alzheimer's, then yes, D, constant reorientation may be beneficial. But for the later stages, it's pretty much in one ear and out the other. Number 3, a client is meeting with the nurse for the first time to assist in establishing needed community resources. The nurse noted in the client's chart a history of attention deficit hyperactivity disorder, ADHD, that can sometimes be disruptive. How should the nurse prioritize the facilitation of the meeting? So you are a nurse meeting with a client. You note that the client has ADHD, and it also says the client can become disruptive. So since we're in a meeting, I don't want the client to become disruptive. So what would I implement or prioritize to make sure that this meeting goes smoothly? And this is an adult. They have cognitive functioning,
I
so
would
they
say
are
D.
stand. D, positively reinforce self-controlled, relaxed behavior, possibly. I see a mix of answers. I see C's, I see A's, I see D's. I see everything but B. Definitely the answer is not B. You guys are on top of that. Listen, they could be going for on and on and on if you just let them just go. So no, we definitely know B is not the answer. So let's see. I see everything but B. The correct answer is D. And yes, whoever unmuted and talked, the answer is D. So let's go back and see the other answers before we talk about the rationales. So A, provide the client with a list of predetermined goals and resources. Now, not saying that that is wrong, okay? Because this is the purpose of the meeting, right? The client is coming to the meeting for this purpose. However, the question was asking you what to prioritize, meaning what is the most important thing. Now, because the client can become disruptive, okay? If that is to happen in the meeting will not be able to continue. So being able to give them a list of goals and resources, it may not even get to that point because the client has disrupted the meeting. So that would not be the priority. The priority would be whatever is going to help facilitate the movement of the meeting. D would help to do that. Positively reinforce self-controlled, relaxed behavior. You want the client to remain in control and relaxed. We don't want them to experience any hyperactivity. We don't want them to experience any type of impulsiveness because that is when it becomes disruptive. So if we put emphasis on self-controlled, relaxed behavior, the goal is the meeting can run smoothly. So I put that as the priority, and then everything else comes after that. So you guys have to be comfortable with prioritization questions. Okay, the NCLEX is going to have prioritization. As a matter of fact, when the NCLEX was last updated in 2023, there was more emphasis placed on prioritizing, delegating, and therapeutic communication because students are having trouble prioritizing what is the most important thing. Again, it's not saying A is not the answer. A will be the answer at some point in the meeting, but that is not the first thing that I need to prioritize. I need to make sure that the meeting runs smoothly. And to do that, I want to put emphasis on controlled behavior for the client. Okay. Question number 4. The nurse is caring for an older adult with mild dementia who has been admitted with heart failure. What nursing care would be helpful for this client in reducing potential confusion related to hospitalization and change in routine? Select all that apply. So again, we know that clients with dementia, they become confused. The confusion can turn into combativeness, aggressiveness. It can make them wander. It can make them upset. So how do I
A,
reduce the risk of
A,
that happening? I hear
A,
A,
D, D, E.
I hear ADE. Anyone else? in the chat. Let's see. ACDF, ADF. I'm seeing a lot of ADs and F. I see a B in there. Okay, you guys seem to be on the same page majority. Okay, so let's look at our answer options. Reorient frequently to time, place, and situation. Put the client in a quiet room furthest from the nurse's station. Perform necessary procedures quickly. Arrange for familiar pictures or special items at the bedside. Limit visitors. Spend time with the client, establishing a trusting relationship. More answers in the chat. A lot of ADFs. Let's see. ADF, y'all was on point. Good job.
Yep.
Good job. Sometimes it's hard to do these select all that apply questions. You get some right and then you get some wrong. And it's like, I don't know. I hate prioritization questions. I hate select all that apply because I could never get it. You just got to keep practicing. But it was good because it was a lot of other options that could have been the answer. So let's go back and see the answers so we know what we are discussing. So ADF. Okay. The client had mild dementia. Okay, so that was the key. Now, mild dementia is easier to manage symptoms. They're more cognitive. They can have periods of confusion, periods of combativeness. You know, it's not as often, but it can happen. That's why I said the symptoms are very vague. It's like you see it, but then you don't see it, or you see it and you're not realizing what is happening. So because this client has mild dementia, okay, we'll discuss C. So because this client has mild dementia, reorienting them does work. Okay. Arrange for familiar pictures. So we talked about creating the need for familiarity. Okay. We want them to feel comfortable. And F, spending time with the client, establishing a trusting relationship. This is also why we will assign the same nurse to the client with each shift that the nurse is there, because it starts to build rapport and a trusting relationship. So someone said C. Okay. Now, what reason would you think you would have to perform anything quickly? Okay. Go ahead. If anyone thought C was the answer, why would you think that you would have to perform something very quickly?
Well, because I was told that like a lot, especially when they're already irritated, or like when you walk in there, a lot of dementia patients don't like you to touch them. So if you can do it quickly, then performing like blood pressure or respirations or pulses quickly, then it just makes it easier for both the nurse and the patient, is what I was told.
Now, you are absolutely correct. And here's the thing, you are not wrong, as a matter of fact. Anytime you have a patient that is a neuro patient that gets aggravated very quickly, we call it cluster care. Okay.
Yes.
You do as much as you can in a period of time so you can leave the client alone. The thing is, this client is mild dementia. Okay. They're not there yet with the irritation. It's there, but like I said, it's not as prevalent. It's not as much of an issue as it is when the person has, the dementia and it has progressed. By this person being early stage dementia, okay, you want to take time to do tasks because they're still cognitive. You can explain what it is that you're doing. And again, we want to keep them as functioning and as involved as long as we possibly can. Now, once they get to the point to whereas they are far advanced with the dementia, then we talk about things like cluster caring and, doing as much as we can quickly to not agitate the client. But they're not there yet. So what you're saying, Nikki, would be applicable, but for the client in the later stages. At this time, they are still functioning, they are still cognitive. You can still have a communication with them, you can still have a conversation with them. So we want to be able to do things and be able to explain what it is that we are doing. That is how you reorient them also, to kind of just talk them through the process.
Okay, so I just misinterpreted the question. Okay.
You know what? That happens. Listen. NCLEX this is what NCLEX is supposed to do. So do not. Oh, I don't want you guys to feel any type of way. If you get questions wrong, do not be discouraged. That is what the NCLEX is meant to do. When they put these questions together, they put what we call distractors in these questions, and you will learn that. Distractors are meant to distract you. Distractors are meant to get you to read something and misinterpret. That is where the critical thinking comes in to kind of feed through all of that, and get to where it is that you need to get to. So the question is doing its job if it distracted you, or I kind of didn't read that. I read that a different type of way. It was supposed to do that.
And
Okay.
also C is conflicted to F, because there is no way if you're gonna spend time with that client and then you're gonna do something quickly.
Oh,
So
that is yes, ma'am. Yes. Who was that?
Oh, good catch.
this is lovely.
Okay, lovely. Yes, ma'am. Okay, listen, if you could see me, my camera ain't working, but I am snapping. You could hear it, but you can't. Yes, ma'am. What a catch. Yes, ma'am. Connect those dots. That is, listen, that's what you're supposed to do. Sometimes, if you don't know what a question answer is, you just got to figure it out, connect the dots. That is exactly the case. How can you do F if you are performing quickly your duties with the client? That is exactly that was so I couldn't have said that any better myself. Yes, ma'am. Okay, that is exactly is a C and F are contraindications. Yes, they are. Question number 5. The nurse is providing care for a client with autism spectrum disorder who has been engaging in self-harm over the past several months. When creating a plan of care for the client, the nurse should include what strategy? So you have a client with autism, so understanding what autism is. What would be the best thing to include in the plan of care? Okay, so let me look at the
That
chat.
B.
Okay, I see bees. I see a
Yeah.
lot of bees.
I
Bees,
think
bees, 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 bees. Well, a lot of bees. Set clear and ambiguous limits on the client's behavior. Encourage the client to express the feelings that motivate their self-harm. Create a tentative one-on-one plan with the client before involving the family. Provide education on the link between ASD and increased risk for self-harm. Oh, some more answers in the chat. I see an A. Okay, Alavina, I may be saying that wrong, and John are going against the grain. And
I
Cecilia,
said B. Still.
and the correct answer is A.
Oh my God.
For the people who went against the grain, the people that went against the majority, you are correct. So let's talk about it. Okay. Now, when it comes to self-harm, okay, you want to set goals or limits on the client's behavior. Okay. Um, Sometimes when it comes to clients with autism, remember, they need structure, they need routine. If you guys remember, okay, they need structure, they need routine. So, setting clear, I'm gonna go back so you can read it. Unambiguous. Unambiguous means it is not confusing, it is clear, it is direct. Okay, clear and direct limits on the behavior. For me to discuss this with a client who is self-harming while they are receiving care, I am saying to them, this is the goals for your care. This is what I expect. That is the routine, that is the structure. Okay, now let's look at the rationale for why. For first, nobody put C, nobody put D, which was accurate. Okay, you do not want to exclude anyone when creating a plan of care. If anything, you want the family there from the beginning to make sure that everybody is on the same page moving forward regarding the client's behavior. And lastly, while it might be helpful to provide a link, it does not do anything for the current present issue, which is the behavior of the client harming themselves. So C and D definitely was something that you could have eliminated right away. So for the rationale for why B is not the answer, okay, focusing on the client's feeling has a low likelihood of benefit in this client due to the characteristics of autism. So again, that goes back to the need for structure, and it goes back to the needs for setting clear goals for behavior. Yes, it might feel like allowing a client to express themselves might be helpful, but that probably would be something beneficial to somebody without autism or someone who doesn't require structure and, you know, goal setting, routine and goal setting, structure, that might be helpful for somebody else. So because they need the routine, because they need the structure, because they need clear goals, that is why A would be the answer and not B. Okay, let me see in the chat. B would be wrong because they may not be able to express themselves vocally or understand. That could be it too, Miss Nikki Ann. It could be. It didn't say that they had a communication issue, but that is something to keep in mind, because sometimes individuals with autism are not able to communicate expressively. They could write it down, they could use other types of ways to communicate, but it may not be as well as we would like it to be. So that is definitely something to think about. As that's also actually a good way to look at the question to answer it, actually. So that's a good job. Sometimes NCLEX questions are way too difficult than these questions. Listen, John, the goal is to prepare you. That's it. The goal is to prepare you. We want you to sit down, and when you take the NCLEX, you say to yourself, you know what? The questions at Naxlex was way harder than these questions. Like, I feel over prepared. That's exactly what we want. Okay. We want you to be prepared. We want you to be able to handle the difficult questions, because again, when you guys take the NCLEX, as you get the questions right, they do get harder. That is the only thing that we know for sure about the NCLEX. When you get a question right, the next question is harder. If you get a question wrong, the next question is easier. And it goes back and forth like that until you are answering questions at a steady rate of correct. Question number 6. When developing the plan of care for a client newly admitted to the unit, the nurse reviews the client medical record. The nurse determines that the client is at risk for wandering based on which finding. So the nurse is being proactive. Based on which finding would the nurse determine that the client is at risk for wandering?
A.
A, of course. A, of course. We just talked about it. Clients with dementia, when they get into the later stages, they are at risk for wandering. So the client does have a current diagnosis of dementia. You want to, watch for the wandering. And sometimes when they get confused, that does increase the risk for the wandering. Okay. Um, let me see. Let me go back to look at the other options with you guys. So history of syncope, that is dizziness, fainting, vertigo issues, that has nothing to do with dementia and wandering. Treatment with anti-anxiety drugs, again, do not play a role in increasing the risk for wandering. And generalized seizure history also do not play any role in the risk of wandering. So this was a pretty easy question, process of elimination to help you get to that answer. So I think everybody got that one right. Question number 7. A client with Alzheimer's disease has random violent outbursts, wanders, and is incontinent. The client can no longer identify people who were once familiar and is unable to identify common objects. What is the priority nursing diagnosis? Now, remember, with priority questions, you are not saying the other options are not important or require consideration. You're just saying what is the main thing, the most important thing. So everybody is putting B, 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 B. And we just talked about this. And the correct answer is B. You are absolutely correct. Risk for injury. Okay. The client is in the later stages, more confused, more combative, more risk for wandering, more risk for self-harm. And sometimes the self-harm is not because they're really meaning to hurt themselves. They're just in a state of confusion, and they can, mistakenly hurt themselves. It's not something that they do purposely for a lot of people. So risk for injury, the highest priority when you are planning the care for this client. The symptoms that they are exhibiting places them at risk for falling, places them at risk for injuring themselves. So you want to just keep an eye on them and make sure that it is the priority. Everything else, yes, it is a component of Alzheimer's, but again, it does not take precedence over the risk for the injuries. Question number 8. A nurse is providing discharge teaching to the spouse of a client who has attention deficit hyperactivity disorder regarding keeping the client safe when the impulse behaviors are being displayed. What should the nurse prioritize when providing education? So you have the spouse of a client who has ADHD, and the spouse is receiving education about how to keep their spouse safe when they have the impulsive behaviors. Because as we said, with the impulsiveness comes a risk for safety because people do things without considering the consequences or if they can get hurt. So let's see a lot of answers in the chat. I see D's, I see a B in the mix. So remember, prioritizing means what is the most important thing to prioritize in the education process. Not saying I won't mention anything else that is in the answer options, but what is the most important thing for me to place the emphasis on based on the client's concern or the spouse's concern?
Safety.
B.
The answer is D. D, 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 D. Let's go back. So remember, when a client is having an impulsive episode, safety is the issue. So we want to remove any objects in the environment that they can use to hurt themselves or hurt others. When you are impulsive, you just do things without thinking of the consequences. You know, you might pick something up and hit somebody over the head to try to get away because you're trying to escape. You're trying to run. You don't know where you're running to, but you're just going. And if anybody in your way, you're going to get them out your way. So that means if I'm going to pick up something and bash you across the head, that's what I'm going to do. So to ensure the client is safe and the people around the client are safe, you want to clear the area of any hazardous objects. Okay, I'm going to go back to the chat. Let me see. Okay, I saw a C and I saw a B. So A, that might be helpful. But it doesn't address the concern of when the client is in an impulsive mood, how do I keep them safe? So A is a good answer and it does help, but it does not address the issue. So that's why A is not the answer. I saw B, make sure your home is quiet. So that's actually not a bad answer. Okay. It does help to limit the stimulus for a client that has ADHD, even autism. So that's not a bad answer. But B is kind of implying that you're going to be quiet 24/7 around the clock. You don't have to have a totally quiet home. Remember, the impulsiveness may be something that comes and goes. It's not something that is always there, especially if the client is on medication and their symptoms are being controlled appropriately. You may not see a lot of the impulsiveness. When the client is having those episodes, you may want to consider doing that to decrease the stimulus, but that is not something that needs to be 24/7. So you don't need to be walking around your own house on eggshells 24/7, thinking that you're not going to upset your spouse. Okay. C, of course, is not applicable. Rigid limits when a client wants to engage in activities that are potentially dangerous. It is the rigid limits that is the key to this not being the right answer. You do want to set goals, you do want to have structure. However, you want to have a little room for interpretation. The rigid limits, it caps, the client. You structure is not always rigid. Routine is not always rigid. Sometimes you have a routine, but I might want to, wear shorts to bed instead of wearing pants. You have a routine of getting dressed before you go to bed. You have a routine where you do stuff in order. However, I might want to change it up a little bit. It's still routine, it's still structured, but I just might want to change it up a little bit. When you have something that's rigid, there is no room for doing that. Okay. Question number 9. An older adult client with primary degenerative dementia is slow in following simple directions and is indecisive selecting clothes to be worn for the day. What is the best approach for the nurse to take? Allow the client to select from outfits and minimize other distractions in the environment. Give the client the opportunity to select from 2 outfits and cue follow through instructions. Like C,
B.
pick an outfit and assist with dressing because the client is too distracted to complete this activity without help. Or time limit the indecision and let the client know that activities of daily living need to be completed faster. So hurry up when you got
B.
time.
I think B.
Let me see. I hear bees. A lot of bees, a lot of bees, a lot of bees. And of course, the correct answer is B. Yes. Now let's go back to look at the other question. So some people might have thought A, even I don't think I saw any A's, but in the event you might have considered A. A is not necessarily a bad answer, but you are still giving them all the options, all the outfits. Remember, the issue is they are indecisive. And this is something that can take all day. You know, like they're very indecisive. They really just don't know what direction they want to go in. So if you allow time to do that, you could be there all day. Now, giving the client outfits to select from, kind of reducing the options. Okay. Two, it's either this one or that one. Not only does it make the decision easier for the client, it limits extra time going into this activity because, yes, you are waiting for the client to get dressed so you can go about other activities. So, two outfits, they still have the ability to make their own decision because we want to encourage that. We want to still allow them to do that as long as they are able to, but you kind of like putting a cap on the time frame that they're going to be deciding because again, this could take all day and you just sitting there like, oh my god, you taking all day. And also they are indecisive because they are confused. Yes, they are indecisive, they are confused, they really don't have no idea what it is that they want to do. So narrowing down their choices does help to minimize the confusion. Picking an outfit, it takes away their ability to be independent. They are still independent no matter how long it takes. You still want to foster that. And a time limit, the indecision, and let them know the activities daily living. That's kind of rude. You know, it's not therapeutic. Remember, we want to be therapeutic, even though it's true. It's just not therapeutic to respond in that manner. Okay. Good job. Last question. Now, this is also big on the NCLEX, knowing how to delegate an assignment. The nurse is making assignments for the unlicensed assistive personnel, which task can be safely assigned to the UAP. Now, this is not so much about what is the client's diagnosis, but this is about the task that the UAP is able to legally do. Okay, so assisting a client with chest tubes during ambulation,
B and E.
feeding a client with a swallowing difficulty, teaching a client how to use a cane, bathing a client with Alzheimer's, turning a client who is poorly nourished. So looking into the chat, D and E,
D and
D and
E.
E. I see B D and E's, I see A D and E's, but it appears to be everybody is on the
I
same
think
page with D and E. The answer is D and
aspiration.
E.
Yes.
Perfect. Okay. UAPs can do basic client care skills, bathing, ambulating, feeding. Okay.
But the
Now,
person has difficulty swallowing, which can cause
that is
aspiration.
exactly why. The reason why B is not the right answer, the person is experiencing dysphagia, which is difficulty swallowing. They are a high aspiration risk. For that reason, the RN will be better suited to feed this client. Once this client's dysphagia is managed or it goes away, then the UAP would be able to take care of client in option B. So yes, D and E. Bathing a client with Alzheimer's, they are, trained to do that. And turning a client in bed who is poorly
D and E.
malnourished, they can do that. Yes, D and E. Perfect. You guys have to be comfortable with delegating questions also. They cannot, it's not that they can't do chest tubes. So it's not that they're doing anything with the chest tube nay. It's simply stating that they are going to help them ambulate. So even though a UAP can assist a client with ambulating, the person has a chest tube, so they are a very complicated client. Anything
Yes.
can go wrong with a chest tube. So
Mhm.
while ambulating, you would want the RN to do that because if something does go wrong, the RN can critically think to figure out what is the issue or what is, the complex, what is going on with the client, especially if the chest tube starts beeping. A UAP would not be able to critically think through that. And yes, they could be very unstable. We do not. Now, taking vital signs, an unstable client, something like that, depending on the situation. But yes, we typically do not want the UAP to do anything that requires critical thinking skills, assessment, evaluation, teaching, anything outside of that, we do not want the UAP to do. Okay. Good job. You guys did well with the questions today. I don't know. Maybe I need to start getting some harder questions, Chad, because y'all be
Yes, please.
but listen, these are NCLEX style questions. That simply means y'all understanding what the questions are. That's a good thing. You're critical thinking. But I'm gonna try to find some real good ones for my next webinar on Wednesday. So if no one has any questions, can you add? So case studies. There should be a location with case studies. I know that came up before, that some students requested more case studies. As a matter of fact, I'm going to post in the link before you guys go, a link in the chat box. And this gives you an opportunity to leave feedback. And I know that, hold on, let me send this to everybody. I know that some students have said in the past that they would like to see more case studies. That is not something that I would post in the webinar with the questions, but there is a location. I know that they do have case studies for you guys to practice, but if you want to see more of them, definitely leave your feedback in this link. As a matter of fact, everyone click on the link and leave your feedback for the webinar. Okay. What you would like to see more of, what you may want to see less of, any type of feedback, criticism, all of that. I love it. Can always learn to do things better. But yeah, that would be your
I have a
opportunity.
question.
Yes.
Okay, so I was doing a cat test, and there was a question. And I mean, I could beat myself, but it was a little bit confusing to me. Okay, so it was a child that came in the emergency, and the child had like bruises, bruises that were already healed and stuff like that. So
Okay.
there were two choices. One was to um
Wait.
alert
Is
the charge nurse.
if this is a priority question?
Ne- Yeah, yes, it
Okay.
was. And it was saying that like to inform the charge nurse or to call the oh Jesus.
It was like ask the child more questions.
Yeah, that would be
Right, right,
whatever
And
answer says to call Child Protective Services.
right.
That is the correct answer.
The fact, okay, so I that's why I said I could beat myself. I click onto that, second guess myself again and said, do you follow the chain of command by going to the charge nurse, or do you just go there and just call the protective service? And I'm like, do you follow the chain of command in this one or what? And I just change it and put it for call the charge nurse, and it was called protective service. I could beat myself for that one.
So here's the thing. You are not incorrect in your thinking. You mentioned chain of command. So that is correct in your thinking. When you are dealing with suspicions of abuse, okay, and that is exactly what you had. What you described, it sounds like abuse. And in pediatrics, by law, if you have signs of abuse, and that could be anything, the physical signs, the stories don't match with the injury, any suspicions of abuse, the chain of command is to first call Child Protective Services. Then you start notifying people. So you are correct to talk about chain of command, but when it comes to suspicions of abuse, the chain of command starts with Child Protective Services. Okay. Now, now being that pediatrics is actually one of my specialties, you do want to make sure that you are, you're doing the right thing, because sometimes you can have a situation, and when you call Child Protective Services, you can't uncall them. So it's not like you can go back and say, you know what, I was mistaken. This is not what it is. Everything's fine. in reality, you cannot unring that bell. Now, does it happen? Probably, because Child Protective Services, those people are very short staffed. So if they get a call back saying, you know what, everything worked out, we were mistaken, they probably won't follow up. But in the eyes of the NCLEX, once you make that call, there is no, unringing that bell. So I make sure my students understand, you want to make sure that you have the evidence that you need to support that call. Because it's not like once you call, you're done with it. You're the one that made the call. You are involved at that point. I actually had a situations like that, and in peds, and I had a client, I forgot his age. He was like, he was older than preschooler age. So about, oh gosh, maybe preschooler, late preschooler, something like that. And he had a lot of bruises over his body, kind of sort of your client in your question. And the bruises were in various stages of healing. Not only that, the bruises was in areas that I don't typically expect children to get bruised. Now we know children fall, they hurt themselves, they break stuff, they get bruised, they get scratched up, they get cut. It happens. I do not freak out every time I see a child with a bruised knee or a bruised elbow or they fell on their face. I don't trip out when I see that. But this kid had bruises in areas that I typically would not expect a child or an active child to get bruised. So it was very suspicious. Now, you don't let the parents know you call in CPS. You got to play it cool. So I made sure to get some assessment, to get some background information to support me about to call, because I asked them, I said, this kid is, either he's very klutzy or, he plays a lot of sports and he gets tackled a lot. And, I'm just making light conversations to try to get an understanding what's happening. And the parents was like, you know what? We're not sure where these bruises come from. Like they just show up. Now, for me, that's suspicious because there's no way a kid can have all of these bruises and you telling me you don't know where they come from or how they got there. So I'm trying to, hurry up to get out the room because I'm about to go call CPS because that makes no sense. You can't tell me this kid has this many bruises all over the place and you can't tell me how they got there. So either you're doing it or you're neglecting this kid. Either way, I'm calling CPS. But then made a um the mom made a statement. Honestly, now remembering, the kid was younger. It was a younger kid. And the mom made a statement and it made me kind of stop. The mom was like, I noticed when I pick him up under his arms, he bruises where I pick him up. That would make me not call CPS because now you are giving me a story that could possibly explain what is happening. So instead, what I did was I notified the healthcare provider, and the healthcare provider ordered some tests. Long story short, the kid had hemophilia.
I was just gonna say that. Oh, it's on some
It was hemophilia.
anticoagulant or something.
And we did the testing because the doctor said, okay, let's run some tests before we start calling CPS because that's what I was supposed to do. But it was mom's statement. And I asked the parents, once we had an official diagnosis, I asked them, I said, you guys never noticed, did he ever have a nosebleed that just wouldn't stop? Or did he ever have, painful swollen joints? Or they never noticed. He probably was just one of those kids that just was not that active because he never really had, according to them, he never really had any active bleeding episodes that made them suspicious. But that's what it was. The kid had hemophilia. So that's why he had all those bruises. They just had no idea, never. Now, we could have called CPS because that's neglect. Like, you ain't take him to the doctor at all to figure out what's going on. But, we spared them because they really was clueless. So it wasn't like they was purposely neglecting the kid. They just really had no idea. It was other kids in the home. Poor child just went unnoticed. But that's what it was. It was hemophilia. So I was almost about to call CPS on those people. They would have lost custody temporarily. An investigation would have been done. They would have been cleared because eventually we would have found out it was hemophilia. But at least we found out first before we called CPS. But that is always your priority in that situation.
Okay.
Okay.
Makes sense. But I mean, the charge nurse, I was just thinking of chain of command,
No,
and
you're
I
right.
just really
You're
said,
absolutely correct. There is a chain of command, but when it comes to suspicions of abuse, the chain of command starts with calling CPS. So you're not incorrect. It's just the chain of command is different in that case. Once you call CPS, then you can notify the charge nurse. Then you can notify the healthcare provider. That is how that works.
hmm,
I have a
okay.
question. What about if the situation escalate? What are we gonna do? We call 911 or what we do?
If there's any suspicions of abuse, you automatically call CPS, even if you're wrong. You know, sometimes stuff just don't look right and you want to be safe. And plus, that's your license. In pediatrics, you have to call CPS if there is suspicion of abuse. Again, the stories don't match. You know, the bruises are suspicious. You call CPS, period. You could be very wrong.
No, my question is like if we are talking to the parents and then they get really mad and they wanna punch us. So in that situation, what do we do?
See, that's the thing. You don't let them know that's what you're doing. You got to play it off.
Okay. So we don't say, I am calling. You just
Oh,
go
no,
outside
ma'am.
and
Absolutely not.
okay,
No.
now I see it.
Girl, no,
You will
ma'am.
get beat up.
Because I was about to say, do I sit at the
No,
door?
listen, you just try to hurry up and get up out of there. You do not be suspicious.
Okay.
You know, don't be suspicious. Don't be suspicious. You know, just finish what you're doing and okay, you know what? I'll be back. I'm gonna go put this in and I'll be back. You know, something to get out the room, but you never let oh no, ma'am, child, no, ma'am. You do not let them know. Play it cool. Get out the room and call and do what you need to do. You do not let the parents know you are suspicious. It's sometimes it's hard to play it cool, especially if it's something so egregious. But like I had another situation where I was assessing a 9-month-old and I took her clothes off and she had little burn marks on her thigh. Now, they weren't like burn marks like some fire burnt her. It was like perfectly round circles and they looked like sores. They were burns. So of course I'm already suspicious because what is this? But I'm gonna ask, get my assessment. And the father made the comment, oh, sometimes when I change her diapers, I'm a smoker. And I change her diaper with the cigarette hanging out my mouth. And sometimes the cigarette falls out my mouth and it burns her. But it's an accident. Now I'm looking at him like, yeah, okay, right. I'm about to call CPS. Now, this is what I'm saying to myself, but I cannot make him, suspicious of me being suspicious of him. So I just said, oh, I said, you know what? I said, you got to be more careful. You got to put the cigarette out or, put it down while you're changing her. I said, if it's falling out your mouth and burning her, I said, that could be dangerous. I said, so, whenever you change her, just take the cigarette out and put it down. And once you're finished, pick the cigarette back up and keep going. And he was like, yeah, you're right. He had no idea I was about 10 seconds from calling CPS. Because I said, this is not the cigarette fell out my mouth and burned her. This looks like somebody is taking the cigarette and pressing it into the baby's skin because it is a perfect circle. So you telling me it just fell out your mouth, that's not enough. So yeah, I was calling CPS. So sometimes you just don't say nothing. Just say, okay, no problem, and keep going. And once you get out the room, then you call quickly.
Hello,
Just
Prof.
I can never work in CP or in a CPS because I have a hot temper for that.
Listen, sometimes it's hard when you see stuff. It is hard when you see stuff. Oh, yes. Yes. I think I heard somebody trying to come through.
Yeah, I have a question. Sorry,
Don't say
I
sorry.
need the advice.
Okay.
Okay, I have an exam maybe in a week plus, and I have done CAT questions up to 10, and all of them high, one very high. Then readiness to test 4, 2 at the borderline, and 2, 1 high, 1 very high. So what advice can you give me?
Okay. So normally what I tell students is the readiness test does provide valuable insight. Um, it's really hard to tell you what to expect because you have no way of knowing what's going to be on your NCLEX. My best advice is if you are comfortable answering random questions, that is the best way to assure your readiness. Because when you sit down for the NCLEX, remember the NCLEX is self-adaptive. That means when once you sit down, there is no, you're automatically going to get this question, this question. It is not set up that way. It is self-adaptive. That means as you answer questions, that is going to determine what next question you get. So, because it is self adaptive and because you have no idea what is coming next, the best way to prepare and feel ready is to be comfortable answering random questions. If you get that feeling from the CATs and the RATs, meaning you can sit down and get any question and feel comfortable answering it. Even if you don't know the answer, even if you get the answer wrong, at least you was comfortable enough to attempt to answer the question or, use your strategies for answering a question like ABCs, Maslow, the nursing process, then yes, you are truly ready to take the NCLEX. Naxlex has a bunch of different tests, a lot of questions, a big question bank. You simply just have to be comfortable with questions. Those reports are good, but again, if you are not comfortable answering random questions, then you are not comfortable enough or ready enough to take the NCLEX. But if you are getting good reports, that means you are answering random questions correctly, then okay, you go for it. But you definitely want to practice with the resources of answering multiple questions a day. And that is how you prepare yourself. So if you need to do another CAT, you need to do another RAT and just randomly answer questions to make sure that you are prepared, then that is just what you would need to do.
Okay. All right. Thank you.
You're welcome.
I have a question. It's my first time, but I don't know really about you. Can you tell me a little bit about you, please?
Oh, okay. You're the first person that asked me that. Of course I can. So you know what? I think we are. I'm gonna stop recording because I like to record the question and answers because sometimes students ask really great questions regarding the webinar. So I like to record the answers. So I'm going to stop recording.